Hello, everyone. I'm Siri Vaith, Executive Director of the Cystic Fibrosis Research Institute, or CFRI, and I welcome you to what promises to be an extremely interesting podcast with Dr. Jeffrey King. Before we get started, a bit of light housekeeping. Please note that the information and insights shared in this recording should not be used for medical diagnosis or treatment. Please, as always, consult with your care team before making any changes to your health management plan. I want to thank our sponsors whose support has made this webinar possible, including Vertex Pharmaceuticals, Gilead Sciences, and Viatris. For those attending the webinar, you can put your questions in the Q&A box. Please not the chat, just to make it easy for us, and we will try to get to them after the presentation. Colon cancer is a growing concern for the CF community. As our presenter will share, those with CF have a far higher risk of colorectal cancer than the general population. Unfortunately, many CF-related GI issues are similar to signs of colon cancer, leading to delayed screening, diagnosis, and treatment. CFRI has been focused on raising awareness of this issue and encouraging our community members to have screening colonoscopies. Many people are uncomfortable or squeamish about this, and it is our intent to help people get over their fears and embrace colorectal cancer prevention. And it was this intent that led to our inviting today's esteemed speaker. A member of CFRI's CF Adult Advisory Committee recently had a colonoscopy and recommended we invite Dr. King to speak. And we are so grateful to you, Dr. King, for saying yes. About Dr. King. He is a gastroenterologist at National Jewish Health, where he serves as chief of the Division of Gastroenterology, is the medical director of the GI Procedures Unit, and an associate professor in the Department of Medicine. In addition to specialties in multiple GI conditions and diseases, including IBS, celiac disease, GERD, pelvic floor dysfunction, and diverticulitis, Dr. King is a specialist in allergy and lung disease-related GI conditions, including cystic fibrosis. Dr. King, we welcome you and thank you for helping to demystify the colonoscopy process. Welcome.
Thank you, Siri. I want to thank you and the CFRI for inviting me to speak today on this very, very important topic. I hope you can see my slides now. So today we're going to be sort of walking through screening colonoscopies and colon cancer in general, and then we'll also be talking about specific issues as they relate to cystic fibrosis, because the process of going through a colonoscopy is a little bit different with CF. So what's the importance really of colon cancer prevention? Well, currently, the colon cancer, as you can see from this chart, is the third leading cause of cancer death. Actually, if you look at this chart, it's number 4 on the list, but that includes breast cancer, again, primarily female disease, and prostate cancer, primarily male disease, and so, or exclusively a male disease. And so the when you take those out by sex, then it is the third leading cause of cancer death in the United States. Nearly all colon cancers start as small polyps, and really this is the whole idea behind the screening colonoscopy. We don't want to wait until the colon cancer has formed to detect it. We want to catch it when it's here on the smaller polyp form, rather than waiting until it's fully become a cancer. The other reason why colon cancer screening is important is that cancers found during screening are typically earlier stage and are more likely to be curable. So the point of colonoscopies is, again, to find polyps when they're at this stage rather than when they've become a cancer, and even a cancer that's actually infiltrated into the wall of the colon. So why does having cystic fibrosis matter, or how does that impact colon cancer? Well, the CFTR is actually a tumor suppressor gene. And so mutations in that CFTR gene, including people who are CF carriers have an increased risk of several types of cancer. And the cancers that typically are at the highest increased risk are GI cancers. So what does a tumor suppressor gene mean? Well, the lining of our intestinal system is constantly turning over and replacing itself. And if we did not have checks and balances on that cell proliferation and replacement, then the cells can grow out of control and turn into cancers. And so we also have tumor suppressors, which keep those cells from overproduction and from turning into cancer. And so it's kind of the brake on the system. When that tumor suppressor gene is mutated, you lose that brake on the system, and now cells are more prone to proliferate out of control and turn into cancers. So in the general population, colon cancer, people are thought to be at about a 4.5% risk of getting colon cancers. About 4.5% of the general population will get colon cancer over their lifetime. With CF, because CFTR is a tumor suppressor gene, it is thought that the risk of colon cancer in CF is 5 to 10 times higher. When you take that one step further, and if you're a cystic fibrosis patient who is post-transplant, you are now at a 25 to 30 times higher risk of colon cancer, which is thought to be related to the immunosuppression, among other things. With cystic fibrosis, the average age of colon cancer onset is approximately 40 years old, which is about 20 to 30 years younger than it is in the non-cystic fibrosis population. And that when you look through the case reports and medical literature on colon cancer and cystic fibrosis, almost all reported cases develop in patients under the age of 50. Now, the big caveat to that is that prior to modulator therapy, the life expectancy, as you all are well aware in cystic fibrosis, was under 40 years old. And so there, even though this sort of makes it seem like colon cancer is happening very frequently in very young folks with CF, I think a lot of it is skewed, a little bit of skewed data, just given prior life expectancies. We expect this to drastically change in the times of modulator therapy where life expectancy has drastically improved. When you look at individual mutations, the literature shows that the highest risk of colon cancer is with patients who are homozygous for the F508 del mutation. And there's a slightly lower risk of colon cancer in non-F508 mutations. So in 2018, the Cystic Fibrosis Foundation put out colon cancer screening recommendations for individuals with cystic fibrosis. And I think this is a really good algorithm to have handy or to discuss with your physicians. If you start at the top up here, the first question is, have you had a transplant or not? For the start, let's go down the no transplant route. Obviously, anytime someone undergoes a procedure, we have a lot of discussions about cost benefit, pluses and minuses, which include anesthesia risk, other comorbidities that you may have, safety concerns. And so if you get past that and you're deemed to be a candidate for a colonoscopy, the age that we start screening with cystic fibrosis is at age 40. Now, in the non-CF population, it used to be age 50. That changed several years ago to age 45. So because of the increased risk of colon cancer in the earlier onset of colon cancer and cystic fibrosis, the current recommendation is to start at age 40. If your screening colonoscopy is normal, you should have a repeat colonoscopy every 5 years. This is another thing that is different from non-CF recommendations. If folks without CF have a negative colonoscopy, in general, the recommendation is 10 years until the next colonoscopy. If, on the other hand, you have polyps or cancer found on your colonoscopy, then you have to come back. You're the lucky person who gets to come back sooner in 3 years to have your repeat colonoscopy because you're thought to be at a higher risk group because of those polyps. Now, if you've had a transplant, as we discussed, your risk of colon cancer is even higher. And in post-transplant patients, the recommendation is to start screening colonoscopies at age 30. Now, if you have had a prior colonoscopy for some reason, before the age of 30, within 5 years, then you can go 5 years after your transplant before you need another colonoscopy. But if you have never had a colonoscopy before and you've had a transplant, then we start at age 30. And the recommendation is generally to have a screening colonoscopy within 2 years of your transplant. And then again, if it's negative, then you go back into the every 5-year screening. And if it's positive, you go into the more frequent colonoscopies. What I will point out here, and we will get to this a little bit later in the talk, is if you look over here in the comments for the figure, is a negative colonoscopy. One of the assumptions that is made there is that there are no polyps on exam, but you also have a good to excellent bowel preparation. And we will get into that. So that means that the endoscopist was able to see everything they needed to see without anything being obscured by stool. And that's very, very important. And we will get to that later on in the talk. So the prep. If you have talked to people who have never had a colonoscopy, in general, most people are worried about the actual procedure itself. If you've talked to people who have had a colonoscopy, prep is usually the biggest issue. You're going to be drinking a lot of laxatives. You're going to be spending a bunch of time in the bathroom. You're going to get very little sleep overnight that night before your procedure. You are going to be hungry probably the day of your procedure, and there's a lot that goes into this. So let's kind of get into the nuts and bolts of the prep. As part of those consensus recommendations, they also made recommendations about how colonoscopy prep should be different with cystic fibrosis. And so you should follow an intensive CF-specific bowel preparation. And what does that mean? So that means that you are going to drink this laxative solution at least 3 to 4 separate times, which again is generally twice as much as you'd be drinking it if you didn't have cystic fibrosis. And each wash should be a minimum of 1 liter or 2 pint glasses. The last wash should be within 4 to 6 hours of the colonoscopy. And this is similar to what we recommend for non-CF patients. What I have here is just a sample prep, and this is from the University of Minnesota. And in the CF world, this is kind of the main gold standard colonoscopy prep. And I think a lot of institutions who take care of cystic fibrosis patients have kind of altered this prep a little bit to fit in with their own institutions' practices. But this is kind of the gold standard for CF colonoscopy preps. And I don't want to go through necessarily this whole thing, but I do want to point out a couple of different things. One is that the main laxative used here is Go Lightly. You can see over here in the shopping cart that you're going to have other places, including my institution uses Miralax. You'll also see that there's magnesium citrate to help start the cleanse a couple of days before the procedure. And then down here is where they talk about how you're going to be drinking the Go Lightly. The first time you start drinking the laxative solution will be at 3 p.m. the night before your procedure. And it's 8 8-ounce glasses. So 64 ounces that you drink at 3 p.m. You also drink another 64 ounces at 8 p.m. the night before. And then you do that final set of 64 ounces the morning of your procedure. So this, you will see, is very different than the recommended colonoscopy prep for patients who do not have cystic fibrosis. As I alluded to in a couple of slides previous, the prep is really the most important part of the whole procedure, in that your colon needs to be cleaned out enough for us gastroenterologists to actually pick up abnormalities in the lining of the colon. So polyps are small bumps or protrusions from the lining of the colon that we can see on a colonoscopy. And I have a couple of examples coming up in future slides. But if you remember what I said previously, is that to be considered an adequate colonoscopy, you really need to fall in this good or excellent prep. Now, what does that mean? That means at least 90% of the lining of the colon can be seen. Anything that's kind of left behind after the prep is mostly liquid, which we can suction out with our camera that we have. And we can see everything really, really nicely here. If you go into good prep, again, you can see more than 90% of the lining. Again, maybe a little bit more liquid stool. You can see a little bit of it down here, but it's fairly easy to clean that out and see everything we need to see. Once you start getting into fair and poor prep, you can see that there's a lot of, there's some liquid stool, but also there becomes some solid stool or semi-solid stool that is adherent to the wall of the colon. And it's very, very difficult to see any polyps potentially that may be under that stool. So we can't say that we didn't miss a polyp in those cases. And so if you have a poor or fair prep, the recommendation is usually to repeat that colonoscopy as soon as you can get adequately prepped. The lower tile down here is called the BBPS, or the Boston Bowel Prep Score. And so this was came out of Boston University. And basically, it's a little bit more of a standardized scoring system for a bowel prep. And what we do is we look at 3 different sections of the bowel. So this is the right colon, the transverse colon, and the left colon. And we give each of those segments a score based on this number system up here, from inadequate all the way up to excellent. And the previous tile that I showed you that said an adequate prep is excellent or good. When you look at the Boston prep score, it's greater than 6, greater than or equal to 6. So that means you have basically good preps, at least in all of these segments. So that's just a more standardized approach that you may see on your colonoscopy report. And that's what that refers to. So you want to be at least at a 6 on the Boston prep score, or a good or excellent. When we get into everybody's kind of reluctance to do a screening colonoscopy, I would say this is the one thing that for me, and as someone who had my own colonoscopy a couple of years ago, this was my biggest reluctance, is was I going to be adequately prepped, and were they going to be able to see everything they needed to see? I was also a little bit more nervous because I'm a gastroenterologist, and I would have been very, very embarrassed if I had a bad prep. So what about the actual procedure day? What's that going to look like? Well, most institutions will have you show up an hour or so before your procedure time. And during that time, you will have an IV placed in your arm so that we can sedate you for the procedure. You will meet generally with an anesthesiologist or whatever anesthesia provider will be covering your case. And then the nursing staff generally has a number of questions that reviews medical history, medications, just so that we're all on the same page about what exactly you have going on. Once we're ready to do the procedure, we get you back into the procedure room. And what we do is we have you lay on your left-hand side, facing away from the physician performing the procedure. Once you're positioned appropriately, we generally do what's called a timeout, where we just verify that you're the correct patient in the room and we're doing the correct procedure and everybody is in agreement. And once everybody has agreed, including the patient, that's when we start giving sedation. The most common type of sedation that is used nowadays is an IV medication called propofol. It's a very fast-acting IV medication that usually works within about 20 to 30 seconds to put you in a deep sleep. You will still be breathing on your own, just like you would be at night when you're sleeping. It is not as deep of a sedation as you'd be sedated for a surgery where you'd have to be intubated and put on a breathing machine. So this is a deep sedation, still breathing on your own, laying on your side. Once you're asleep, the colonoscope is inserted into the rectum. It goes up the, so this is the patient facing away from us. So it actually goes up the left side of the abdomen. That's the, the descending colon. It goes across the upper colon, which is the transverse colon, and it goes down the right side, which is the ascending colon. So right here, you can see the small intestine attaching to the colon. That's called the cecum right there. That's where we want to get to if we've done a full colonoscopy. At the bottom of the cecum, what you see is this little growth off the end. That's the, that's the appendix. And so from the inside, you can see a little half moon shape for the opening of the appendix. And so in every colonoscopy, you should have the GI doctor should be taking a picture of that area to verify that they've gotten that far. That's kind of a landmark that we use to show that we've seen the whole colon. In general, we certainly look for polyps. We don't ignore polyps as we are going in. If we see any, we can take them out or biopsy them. But in general, most colonoscopies, the goal is to kind of get where you're going and then spend most of the time looking for abnormalities on the way back out. And so that's what's called withdrawal time. And there are recommendations for the amount of time that the endoscopists should take as they're coming back and pulling the scope back and looking at the colon. The longer you take to look, the more likely it is you're going to find polyps. So if you find out that you went in for your colonoscopy and 4 minutes later you were out in the recovery area, may not have been the most complete colonoscopy. Once we are inside the colon, what we're looking for, as I said, are polyps or little growths of the lining of the colon. And here are a couple of examples of what they can look like. And this is the colonoscope or the camera that is inserted into the colon. And on the end of the colonoscope, there's a light, a very bright light that shines there. There's also this suction port, which allows us to clear any residual prep that may be in the colon. And it also, if we remove a polyp, we can also suck the polyp up through the suction port and catch it in a little trap that we put on the end of that, which allows us to be able to send it to pathologists. And then through this third little opening right here, we can put all the different tools that we need to remove polyps, take biopsies, or do whatever procedures we need to do during the colonoscopy. So there's a couple of different ways that we remove polyps. This first picture here is what's called a snare. And it's kind of like a lasso that gets put around the polyp, and that can be cut off as we close that snare, it can just cut through the polyp. And if the polyp is a little bit larger, we may even apply heat to that snare to basically cauterize off that polyp. So there's hot snares and cold snares. You may see that in your report. And then over here, we can also put what's called a forceps, or basically a tweezer, that we can grab on to very, very small polyps and remove them that way. And that's also the way that we do biopsies. In general, most recommendations now are to take polyps off with snares, if at all possible. There are some polyps that are very, very small that it's hard to really capture with a snare, that we will do with biopsy forceps. Here is a picture of an actual colonoscopy, and this kind of shows you how difficult sometimes it is to see polyps. And so in this panel A here, you can see a very faint outline of a polyp, and this is what a polyp may look like. And then this is the snare, as I mentioned, placed around the polyp. Here's the polyp right here in the middle. And then here is the cold snare as it is closed, cutting through. You can start to see a little bit of blood cutting through the lining. And then this is what it looks like afterwards. So this is not, when we remove the polyp, we're just removing that kind of superficial lining of the colon. The wall of the colon is still completely intact. This does not put a hole in the wall of the colon or anything like that. And that's what it looks like afterwards. Now, this is all very much magnified. This is a tiny, tiny little, this polyp is probably, I don't know, 3 or 4 millimeters in diameter. This bleeding, it's kind of like cutting biting the inside of your cheek. It may drip a little bit of blood for a few minutes, but it heals up very, very quickly. Here are some colonoscopies that I've done over the past couple of weeks to months. And here's what polyps can look like. Again, this is a very, very good prep. You don't see a lot of residual stool here. Maybe in this second window, you start to see a little bit, but that's easily cleaned off. But you can see these little bumps, this little bump. This is what we're looking for. So you can, I mean, this one is fairly conspicuous, but you can imagine if you're kind of going through really quickly, you may miss something that looks like this. So you really do need to take your time. We look around at every wall of the colon. As you can see here, there are a lot of folds in the colon that you need to kind of look behind to make sure you didn't miss anything. What you'll also see is the colon is kind of wide open and inflated. That's because we put air into the colon while we're doing the colonoscopy to help expand it and allow us to see everything we need to see. Here's a little bit of a bigger polyp, and this one is a more concerning looking polyp. This one was kind of on its way to becoming cancerous. And so again, a fairly prominent polyp here that I removed with a snare. And so this is, as you can see here, the polyp is completely removed. It's in a jar in a pathologist's office and will never cause that patient any issues going further. Here is a colonoscopy that I recently did on a CF patient that was post-transplant. There are a lot of reasons why CF patients are typically more difficult to clean out. The motility or movement of the intestinal system is generally slower in CF. The secretions and mucus tend to be thicker, stickier, stick to the wall. And so it can be very, very difficult to clean out. And so you can see here that this was an inadequate bowel prep. Lots of mainly solid or semi-solid stool here. That's basically obscure. I mean, in this picture, you can't see any lining of the colon. Like here, you can see a fair amount, but all of these pictures really show you that you really can't see much. Now, we'll oftentimes still try to do as much of the colonoscopy as we can, because sometimes we find in the lining that we can see, we do find things. So if you see down here, it's a very subtle little bump right there. That's actually a polyp that we still were able to see in this patient, and we removed it. But as we suctioned up the polyp, because there was so much stool in the remainder of the polyp the polyp was basically lost in the suction trap with all the stool. And so we weren't even able to send it to the pathologist to see what type of polyp it is. And so the prep is very, very important, not only in us discovering, finding, and being able to remove polyps, but it's also being able to retrieve them, to get them, to be able to send them to the pathologist to see what type of polyps they are, because that also, the type of polyp can have an impact of when we would recommend you coming back for your next colonoscopy. So here's the next few pictures. This is what we don't want to see when we're doing a colonoscopy, okay? So here you can see this big sort of mass here. You can see it's kind of oozing a little bit of blood. That's even, we kind of came around the corner and this is what we saw. There's some darkened black areas to it. Here's a little bit of a better picture of the other side of that area. And so this is a very large growth in the wall of the colon. Here's another picture of it. Again, easily to bleed, some darkened black areas, some ulcerated areas. You really don't see any blood vessels like you do here in the normal colon lining. So this is colon cancer. The patient who had this, we did his colonoscopy because he had recently been found to have iron deficiency anemia. And when we reviewed his history, he had actually had, it's not that he just forgot about colonoscopies or never wanted to get a colonoscopy. He actually had done a screening colonoscopy, but it was more than 10 years ago. So even though that colonoscopy was normal, that doesn't mean you're out of the woods and you don't have to keep up with our current recommendations. This is in a non-CF patient, and that's why the recommendation for him would have been 10 years to repeat his colonoscopy. That patient actually went and had surgery, had this part of his colon removed, and was cured of his colon cancer. So even though we caught this at a later stage, he still had a very, very good outcome. So are all colonoscopies equal? And this often is a question that's asked of me. Can I just get my colonoscopy done wherever I want to get it done? Well, here are the important things for you to consider when you're thinking about where to get your colonoscopy done. The most important quality indicator is a measure called ADR, or adenoma detection rate. And what does that mean? That is the percent of average risk people having an adenoma found during screening colonoscopy. An adenoma is a type of polyp that is at risk of turning precancerous or cancerous if it is not removed. There's another type of polyp that we will sometimes find on colonoscopies called hyperplastic polyps, which are generally not thought to carry any cancerous potential, particularly when they are small in number. So this ADR, so how many patients that I do a colonoscopy screening procedure on, do I find an adenoma? Just to back up a second, screening means that you are only getting your colonoscopy because you're of the age where you need to have one done and it was recommended by your doctor. This, by calling a colonoscopy a screening procedure, that means you have 0 abnormal GI symptoms and you have no family or personal history of adenomas or colon cancer. So a screening colonoscopy is an asymptomatic individual getting a colonoscopy just because it's recommended based on their age. The American College of Gastroenterology Task Force recommends that to be an adequate GI provider doing colonoscopies, your ADR, adenoma detection rate, should be at least 25%. And if you're primarily doing procedures in men, it should be 30% or higher. And if you're primarily doing procedures in women, it should be 20% or higher, because men are, colon polyps are more common in men. But this is, what I would say is, this is the floor. If you're below an ADR of 25%, that really means that you're probably not doing very quality colonoscopies on a regular basis. And so this is something that it's a reasonable thing to ask of your GI doctor. What is your ADR? A lot of institutions and private practices actually publish their ADR rates on their website. So it should be fairly easy to get at. And again, the higher the ADR, the better. That means that GI doctor is finding more polyps on a regular basis. And so why is this ADR important? Well, for every 1% increase in adenoma detection rate, there's a 3% reduction in post-colonoscopy colon cancer incidence. So that means someone getting colon cancer after a colonoscopy before they were scheduled for their next colonoscopy. So that basically means that a polyp was missed during your colonoscopy. So there is a significant reduction in colon cancer risk in that interim between your next colonoscopy for every 1% increase in ADR. And there's also, for every 1% increase, there's a 5% reduction in colon cancer mortality of those colon cancers that are found during that interval. Why is bowel prep so important for all this? Well, with inadequate bowel preps, that fair or poor bowel prep, the adenoma miss rate is anywhere from 20 to 50%. And so that's why if you come in and have an inadequate bowel prep, we will recommend that you repeat your colonoscopy as soon as possible, as soon as you're able to get adequately prepped, because we do not want to miss. The whole point of a screening colonoscopy is to find polyps before they turn precancerous, so to find these adenomas. I'm just going to touch briefly on another screening tool that a lot of people will talk about or ask about, which is called Cologuard. And this is a stool-based test that you'll see advertisements on TV, and you basically send in a stool sample to the company. And basically what they are looking for is DNA mutations or DNA changes that are typically seen with what are called advanced polyps. So those polyps that are very large or right on their way to becoming colon cancers, or DNA changes that we see in colon cancer itself. So Cologuard detects approximately 42% of large polyps, whereas colonoscopies detect up to 98%. And so a large polyp is thought to be 1 centimeter or 10 millimeters or greater. So here is, this is the Cologuard test in the blue, showing how basically frequently they are able to pick up colon polyps of different sizes. And so from 1 or higher, their detection rate is about 42%. And again, it gets down into the 20% range when you start talking about much smaller polyps. And so this is a conversation I often have with patients when they're asking me, do I really need to do a colonoscopy? Can I just do a Cologuard? And really, this is important to understand, is that Cologuards are pretty good are very good at detecting colon cancer, but are not as good at detecting these precancerous polyps. Certainly not nearly as good as colonoscopy would be. When we send our polyps off to the pathologist, the one thing we're really looking for is called dysplasia, and that is basically precancerous changes. That polyp has already started the transition to cancer. Cologuard detects about 70% of those high-grade or very late precancerous changes. So that means 30% of polyps that are basically just about to turn cancerous will be missed by Cologuard. These are some percentages, and basically what this shows right here is that 8% of patients with colon cancer actually had a negative Cologuard. So a negative Cologuard certainly doesn't rule out the possibility of having colon cancer. And what this over here says is that about 13% of the patients in the study had a positive Cologuard test, but then when they went and did their colonoscopy, there was nothing abnormal. There was no advanced polyps or colon cancer seen. So it was kind of a false positive test. So you have more false positives and false negative tests with Cologuard than you do with certainly with colonoscopies. Currently, the Cologuard is recommended for average risk individuals. So that means no family history or personal history of colon cancer or colon polyps, no symptoms. And because cystic fibrosis puts you at an increased risk of colon cancer, you are not thought to be at average risk, and thus Cologuard currently is not a recommended option in cystic fibrosis. There is a current study called NICE-CF, which is a study of non-invasive colon cancer evaluation in cystic fibrosis. And this is basically comparing Cologuard and another stool-based testing called FIT to screening colonoscopy, particularly in CF patients. And we're about 2.5 years into that study now. It's getting close to being closed out, and we hopefully should be getting data on that shortly to see if Cologuard may be a consideration for colon cancer screening in CF in the future. So take-home points from today's talk are that CF mutations increase the risk of colon cancer over patients without CF. That screening colonoscopy with polyp removal is the only way to prevent colon cancer. And that polyp detection is key, it's paramount. That you really need to be diligent about following your prep instructions closely, and you need to make sure your GI physician, and this is even more important, is giving you CF-specific bowel prep instructions. That's why it is very important to see a GI doctor who is knowledgeable about cystic fibrosis. Once you have your colonoscopy done, make sure you follow the repeat colonoscopy recommendations so that you can pick up polyps as they may arise in the future. As I said, find a doctor who understands the nuances of colon cancer screening in CF. There's really two things that come with that. One is really an understanding that the prep should be different in cystic fibrosis. Second, the age that you start doing screening colonoscopies and the interval with which you repeat them is different. I saw somebody 2 weeks ago that's a CF patient that just had a colonoscopy done somewhere else. They were told it was normal and they should come back in 10 years. We had a discussion about why that's not true. And again, you just do run into risk of colon cancer if you are not following CF-specific recommendations. The last thing is, you know what? Colonoscopies aren't that bad. The medication's really good. You get a really nice nap. No one's going to talk about what your butt looks like after the procedure. I was, as a GI doctor, I actually had my colonoscopy done where I work by one of my colleagues with all the people I work with every single day in the procedure, helping out. I was very much worried about all that. Like, nobody ever talks about what you look like when your pants are off, okay? So if anything, the only thing people may remember, and they won't remember necessarily about with your name, but they'll remember your prep. So everybody in that room will remember a bad prep. They won't remember a bad butt. So don't worry about that. So with that, I'd like to end my part of the presentation. I will stop sharing my screen and then open up the floor to questions.
Dr. King, thank you. That was so incredibly informative. I learned a lot, and we do have questions. We have questions in the Q&A. There's a couple in the chat, and then I have some of my own and some that people have texted me. So
Excellent.
We'll try not to keep you here all day,
That's
but
all right.
let's start with the Q&A box from Luann. I'm post-lung transplant patient, age 69, who has ongoing CF-related gastro issues. I'm wondering if age plus CF puts me into a higher category of risk.
Yeah, I mean, certainly age is, there's a reason why we don't do screening colonoscopies on 5-year-olds or 10-year-olds, right? So age is, these colon cancers, colon polyps take time to develop. There's also a lot of factors that go into the development of colon polyps and colon cancer, which include a lot of environmental things like diet, smoking, alcohol use. There's a lot of different factors that go into that. And so the longer you're kind of exposed to those environmental factors, the higher your risk may be. So as with most cancers, it's a combination between genetics and it's a combination between environment. And so certainly Family history is an important factor in that, but certainly age and the cystic fibrosis, and again, being a post-transplant patient puts you at even a higher risk based on the immunosuppression. So absolutely. A lot of people will ask, well, what age can I stop doing colonoscopies at? Current non-CF recommendations are to screen for colon cancer between the ages of 45 and 75. And then usually after 75, it's kind of a case-by-case basis. For folks who are at above average risk or higher risk, then I would, again, continue to follow those 3 to 5 year intervals that are recommended. Every time you're coming due for your next colonoscopy, have that conversation with your gastroenterologist about your medical conditions. What's my life expectancy, basically, right? I tell people, I see a lot of people who are 80 years old who are doing triathlons and are probably going to live till they're 100, right? They should probably keep up with their screening colonoscopies. We see other people who just had a heart attack last week and are on dialysis 3 times a week. Well, their life expectancy probably isn't as great. And maybe it's not as, focus on some of these other things, maybe before your screening colonoscopy. So there's really a lot of factors that go into that.
So you mentioned the Miralax prep. Have you found that to be as effective as the Go Lightly? And do you recommend the magnesium citrate? Because I think that's what it was, with Miralax prep as well.
Yeah, so my institution actually uses Miralax prep. We don't use Go Lightly for our preps, and I've had very, very good results. Actually, the person who I showed, our CF patient with the bad prep that I showed the pictures of, actually did not get the proper prep instructions. So that was part of the issue. They did kind of a standard colonoscopy prep and not necessarily the CF specific prep. And so, yes, we use Miralax here. I think it works just as well. I think we are in the process of updating our prep to really fall in line with the current recommendations, are 3 to 4 washes, 1 liter per wash. So we are updating our prep to even get a little bit more aggressive with our CF prep, but I have had very, very good results in using Miralax, and I use Miralax almost exclusively for my non-CF patients as well. So I think it is very, very good. And I mean, it's effectively the same chemical compound as Go Lightly. So mag citrate, again, can be an additional laxative that is used. We don't use it in our prep here, but again, you can't get too cleaned out. So it's never a bad idea to take more than you need.
I am post-transplant with CF, 65 years old, had colonoscopy this morning. I used souffle prep and magnesium citrate with Dulcolax, was told prep was not great. Do you recommend Go Lightly over souffle? 1 polyp was snared.
So again, my big question would be, was that again a CF specific prep where there were 3 to 4 washes done, 1 liter per wash, or was that a standard sort of non-CF colonoscopy prep recommendation? I don't know. The other thing is, what are baseline bowel movements like, right? Do you tend to be very constipated or have slow motility at baseline? You may need more prep than what is recommended. If you tend to run more on the diarrhea side of things at baseline, maybe you don't need as much prep as what we're recommending. And so what I always tell people is the prep instructions we give patients are really the average of what it's going to take most people to get adequately cleaned out. But every person is very individual. And so what I always tell my patients is, as you are doing the prep, what we expect to be, and I should have put this into my presentation, but we expect to be coming out is basically, it doesn't have to be clear like water liquid coming out, but something that looks like urine, lemonade, apple juice, some sort of yellowish, complete liquid with no particles, chunks, or anything in it. And if you've followed your instructions and there's still chunks and particles coming out, drink more. Get more prep and just keep on drinking until what's coming out. And the other side is also this: if you've done 3/4 of the prep and it's apple juice coming out, you probably don't need to go crazy doing a lot more of the prep. And so we just use that as a general sort of or suggestion about how much prep you're going to need, but you can kind of fiddle with the prep based on your particular situation.
Next question. I have low immune system with very low natural killer cell activity, and I'm concerned about contamination and or exposure to germs and or infections during the procedure.
That's a really good question. You know, a lot of patients ask questions about kind of complications of the procedure, and I'll speak to that in a second. I'll first just kind of talk in general. I always tell my patients there's really two groups of complications that we worry about in the procedure. One is the risk of anesthesia, right? Once you're sedated, particularly in someone with cystic fibrosis whose lungs aren't perfect to begin with, will you have issues with breathing, oxygen? What's your heart rate, blood pressure going to do? So there is risk of anesthesia that we always assess. And then there's a risk of us actually putting a camera inside of your body and removing polyps and doing biopsies, right? And there, with that, there's a risk of perforation or us putting a hole in the lining of the colon. That's a very rare risk, about 1 in 2,500 to 1 in 5,000 risk of that. There's a risk of bleeding, particularly if we're taking out a polyp or a very large polyp. And then the third one a lot of people will ask about is infection. And that one really is kind of the lowest concern for a colonoscopy. And there's a couple of reasons for that. The main reason is your colon is not a sterile environment to begin with. So it's not like we're putting bacteria potentially in a place where there isn't already bacteria. It's a very bacteria-laden environment. And so we are not really introducing bacteria. There was a lot of press, God, it's probably going on 8 to 10 years ago now, at least. I lose track of time, about people getting endoscopic related infections from the scopes that are used for procedures. Those procedures were a different type of procedure called an ERCP, and that's a special endoscopy to look into the bile ducts and to remove gallstones and things like that. That camera has a separate part on it that allows the camera to look out the side of the scope rather than forward. And it has some instruments that you can put out the side of the scope. There was some area there that moves up and down that was difficult to clean. And they found that those people were getting infection, that were some that were getting infections. They were not from EGDs or upper endoscopies or colonoscopies. So the risk of infection with colonoscopy is very, very low. Now, on the other hand, if you have very low white blood cell counts, you're on chemotherapy or, immunosuppressed for whatever reason, certainly keeping an eye on blood counts before your procedure is important, because there are cutoffs below which, yes, you're at risk of infection, basically doing anything during your day, and certainly doing anything that may be a little bit more invasive wouldn't be very wise. But in general, infection risk from a colonoscopy is exceedingly low. I've been at National Jewish for 10 years, and I'm the medical director of our procedures unit. There has not been a procedure-related GI infection since I've been here. So it's a very rare circumstance.
So I have questions from the carriers. In that, studies have shown there's twice the risk for carriers just by virtue of having one copy of the CFTR gene. So if they have double the risk, if people have family history or have been found to have precancerous polyps, should those people be on a 3-year revisit or a 5-year? And then somebody else had wanted to know, how long does it take for a polyp to become malignant? So I'll just throw that in there as part of that.
Good question. Let me answer that one first. That's an easier question. It's thought that it takes about 10 years from a polyp to turn into a cancer. And so that's why the recommendation is 10 years for patients without CF, the kind of average risk individuals. It's about that 10-year plan. So that's where a lot of people will ask me, like, oh, 5 sounds like it's way too long. Like, that worries me. Well, again, we're not the point in doing the colonoscopies isn't to not find any, right? The point is to find polyps and remove them. And so we do need to give the polyp enough time after we did assuming we found every polyp and removed every polyp, we do need to give the colon some time to grow those new polyps for us to find them and remove them. Because again, if they're tiny dinky things that you can barely even see, then it's, the colonoscopy isn't necessarily worthwhile. So the question about carriers is a really interesting one. And, and as I said, the mutations that are highest risk are these two mutations or homozygous mutations for the F508, but that doesn't mean the other mutations or only having one mutation doesn't mean anything. It does certainly increase the risk. And so I think if you have any CF mutation, you should really be following that algorithm that I showed, where the recommendation should be starting. Again, the current recommendation is at age 40. We can kind of debate about whether or not that's correct. And I think probably as we get more and more data, as we've seen with non-CF patients, that recommendation may even move earlier. But at the very least, following that algorithm, starting at age 40, never going longer than 5 years without a colonoscopy. And certainly, if you have a family history of high-risk polyps or colon cancer, or you yourself have any polyps, erring on the side of being more conservative and going at that 3-year recommendation. Yep.
Someone wanted to know if you've seen a change in PrEP for people who are using modulators.
Yeah, that's a really good question. Certainly the PrEP instructions have not changed in the era of modulators. In my GI clinic, it seems to kind of be all over the place, where I have some patients after they start modulators where their bowels work much better and they don't need to be on Miralax on a regular basis or do go lightly cleanses on a regular basis. Everything's moving a little bit better. I have other patients who are just as bad on modulators as they were before, or even I've had patients who have been able to come off of their pancreatic enzymes on modulators, other people who need more pancreatic, right? And so this all fits in. The enzymes and the motility and the function of the bowel really all play a part in the PrEP. And so we have still not changed our PrEP because of modulation. There's certainly no recommendations that I've heard from any of the CF societies about that. So again, never hurts to clean it out extra.
Well, unbelievably, we have spun around the whole hour. I don't think we have time for more questions, but I do want to let people know, because that was another question. This will be available almost immediately on our Facebook platform, because we are streaming right now, but then almost immediately, hopefully within a week or so, we will have this released as a podcast on YouTube, and people will be able to access it there, because yes, such valuable information, and the slides are so useful. The other thing I want to share is that for people who don't know this, if you're an adult with CF and you have a colonoscopy scheduled, contact CFRI at cfri.org. We'll send you compliments of our CF Adult Advisory Committee, a colonoscopy care kit that has some of the things that were in that photo that Dr. King shared, with the wipes and the hand bidet and the Jello, and the, we'll take care of you. So please reach out. We really want to encourage people to screen, as Dr. King has made so evident. Colonoscopies are the gold standard. They are the key to prevention of colorectal cancer. So, Dr. King, I want to thank you so much for taking the time to meet with us, to share your expertise, your insights, and I am sure more questions will come in afterwards for you. So this conversation may continue. So thank you so much. Thanks to everybody who was here today.
Thanks, guys.
All right.
Bye.
Okay.